Great. Thank you very much. I appreciate very much the invitation to present here. So the learning objectives for the discussion today are first to learn the changes in the PAH clinical profile that have emerged over the last 30 years, learn the effect of contemporary therapy on PAH outcome, and review the natural history of PAH to identify opportunities for improving outcome. And I think as an outline, we'll follow the following three main points. Focusing first on early registry and outcome data, the evolution of progress in outcome in the post-therapy era. Those would be the major classes of vasodilator treatments, and to explore contemporary concepts in the natural history of PAH. That'll be the sequence that we go through. So it was really Brinton from Guy's Hospital in London that made among the first pathological observations identifying severe remodeling of distal pulmonary arterioles in a younger patient that presented with end-stage heart failure, ultimately diagnosed to become what we know as pulmonary arterial hypertension. And in 1973, the World Health Organization organized the first standardized hemodynamic definition, which really consisted of a few individuals in a room identifying their opinions as mean pulmonary pressure not normally exceeding 15 millimeters of mercury, and then making the conclusion that it should never really exceed 20. And as a result, pulmonary hypertension had been defined for many years based on this information as a mean pulmonary pressure of equal to or greater than 25 millimeters of mercury. And that definition held for about 42 years and was used to organize patients in the first US National Registry in 1986 that included 187 patients. And as you can see here, these are sort of basic demographic and clinical parameters of that cohort, noting that these are patients largely with severe pulmonary hypertension, an average pulmonary vascular resistance of over 25 Wood units, and ultimately would be the first cohort used to systematically define the clinical profile of this disease. The first major advance in therapeutics for pulmonary arterial hypertension was published in 1996 and involved the administration of intravenous epoprostenol. These are the 81 patients in that original study, very similar to the NIH cohort that I had just shown, although perhaps not quite as severe in terms of their pulmonary hypertension degree at the time of enrollment. But nonetheless, there was the promising signal towards an improvement in survival among patients within approximately 4 to 8 months, lasting to about 12 months compared to standard of care, which was at that time really no disease-specific opportunities. And this really began and gave birth to the contemporary era of medical therapy in PAH. And as I mentioned before, this initiated around 1995. And then subsequently over the next 3 decades, there would be a number of different medical therapies targeting one of 3 different molecular therapeutic pathways: prostacyclin signaling, endothelin receptor antagonist signaling, and nitric oxide signaling. And these would give rise to many different types of clinical trials to help characterize the impact of those treatments on outcome. These are summarized in a nice sort of synopsis by Nazareno Gallier, sort of organizing data from 1990 to 2010. And of course, more recently, there have been a number of different advances as well. We expect to see sotatercept on this list not long from now. But the next part of this discussion will focus really on the clinical data that we have from this collection of trials, all of which are summarized here in this forest plot, indicating the collective impact of these treatments on different outcome measures, largely 6-minute walk distance and measures of clinical progression in PAH, showing that on the balance, there is a clear trend towards improvement in clinical events and improvement in disease course among patients that are treated with these therapies. There's also a clear signal, at least based on the collection of clinical trial data that I show here, of a relative impact of 44% decrease in mortality. And so these are quite promising. And the question has always been, to what extent do these clinical trial data truly translate into real world results? Because of course, clinical trials offer a very protected situation to manage patients that may not always be accessible to us in practice. Professor Mark Humbert published in 2010 in Circulation information to help guide our understanding of how well we're doing in real world practice. This is a nationalized registry in France involving 674 patients, of whom 354 had idiopathic, familial, or anorexigenic pulmonary arterial hypertension. And it was those data that showed an important advantage in survival among patients in the contemporary era that would be observed relative to that original NIH registry. Of course, still at 3 years, the overall hazard event rate was unacceptably high, approaching about 35 to 40%, even in this era in which the 3 vasodilator signaling pathways are used as a target for treatment. This gives some indication a little bit on the risk factors that emerged from that French study. Of course, low cardiac index, important. The starting point of right atrial pressure also associated with differences in outcome. Female sex didn't seem to be as concerning as male sex for outcome, but nonetheless emerged as a univariate risk factor for early mortality in that study. So this really gave rise to the question of whether or not the approach to treatment could be an opportunity for us to change outcome rates. And so this gave rise to the question of whether sequential add-on pharmacotherapy versus upfront dual pharmacotherapy could be important considerations when approaching our treatment of patients. And then also we'll talk briefly about how we rethink the natural history of PAH to try to improve outcomes moving forward into the next era. This table here shows different class recommendations from the 2013 World Symposium Pulmonary Hypertension Guideline document. And as you can see here, we're starting to organize data in a very sophisticated way, suggesting different potential combinations of medical therapy based on different World Health Organization functional class status presentations. And I think a lot of this really hinges and is derived from clinical trial data from Gerald Simonow and many others, starting to approach questions around combinations of treatment and the best way in which we can add those on in clinical practice. This is from the early trial in which the addition of sildenafil to long-term intravenous epoprostenol was studied in 267 patients, and one arm was randomized to placebo. The other arm, already on epoprostenol, was randomized to varying doses of sildenafil. And this was a large global international study that included 41 centers and occurred over 16 weeks. And as you can see here from these data, there's an improvement in the mean change from baseline in 6-minute walk distance among patients that were randomized to the addition of sildenafil. This effect was stratified by baseline 6-minute walk distance, but nonetheless, on the balance, we're seeing an improvement in overall outcome as defined in this study, including clinical worsening events, which at that time was a pretty sophisticated endpoint compared to the predecessor trials from that point. Nazareno Gallier would go on to understand, using his national referral center data set in Bologna, Italy, what the impact of drug treatments were from 2003 to 2013 in real world practice. And so he retrospectively analyzed data among patients who were enrolled in his center. These are the different clinical parameters that were included in patients in those data sets. And the question was really, what is the effect of sequential addition of medical therapy on trajectory of pulmonary arterial hypertension when assessed every 3 to 4 months? These are patients that were largely either on sildenafil or the endothelin receptor antagonist bosentan, and were added on to the opposite medical therapy, which just simply reflects the main medical treatments that were available at the time of the study. And you can see here that different parameters were checked at 3 to 4 month intervals. And his findings show the following differences in survival over 1, 3, and 5 years. These are the hospitalization-free survival rates over the same period of time. And you can see that they compare as follows to different registry data sets focusing on pulmonary arterial hypertension, including the REVEAL registry, the French registry, and then supplemental work from Sitbon and colleagues that was published more recently. And so I think what we're seeing here is a little bit of an uncoupling between clinical trial data that suggests a very favorable outcome under highly controlled circumstances, and registry data suggesting from real world practice that there are still major gains and opportunities for improving and narrowing this outcome gap that still challenge the field of pulmonary arterial hypertension. This led to a shift in the approach to initiating medical therapy for at-risk patients. These are data from the AMBITION trial studying the effect of combination tadalafil plus ambrisentan compared to monotherapy alone in incident newly diagnosed patients with pulmonary arterial hypertension. The investigators in this study used a time to event of clinical worsening endpoint that included each of these different clinical events: death, PAH, hospitalization, among others. And we can see here that this trial was a blazing success across the board. There was a relative 50% risk reduction in the combination therapy relative to the pooled monotherapy group. And there were outcome results that were internally consistent with that across various secondary endpoints, including internal BNP level, long-term dose response, and 6-minute walk distance, among others. And so this really cast into new light the approach to pulmonary arterial hypertension therapy, really focusing on identifying patients earlier in their course as a strategy to initiate aggressive upfront medical treatment, as can be done safely, as a way to mitigate adverse outcome events, including hard clinical events such as mortality and PAH hospitalization. And so the trick has always been, how do we sort of shift this curve from the early treatment stage more closely to identifying patients for whom we can intervene earlier. Our group has identified 3 potential strategies by which to accomplish this: improved initiation or implementation of genetic screening in selected populations, developmental screening, which I'll talk about in just a moment, and then the implementation of exercise as a provocable strategy for identifying patients who may have symptoms associated with pulmonary vascular disease who would otherwise not necessarily meet the true hemodynamic criteria of PAH at rest. And so to this light, I think it's important for us to briefly rethink what PAH means in the current era. We have certainly identified a number of different and novel risk factors for the development of this disease. Here we have the classical risk factors, which have been reported on widely already. But I also want to point out that there are newer risk factors acquired that have emerged recently. We're in the middle of a worldwide methamphetamine epidemic, and it's clear that methamphetamine use is an important and very contemporary trigger for vascular injury in the pulmonary circulation. This is a remodeled blood vessel among someone who was a user, and you can see the packing agent here in white causing a mechanical injury and an injury defined by oxygen stress that causes vascular effacement to distal pulmonary arterioles. So recognizing these newer risk factors is important for us to screen patients appropriately in the clinical setting. And I think also more apropos to perhaps this audience, getting to issues that adult cardiologists and pulmonologists have overlooked for many years, the role of developmental biology in identifying at-risk patients for pulmonary vascular disease. We know that perinatal events, prematurity, other developmental lung disorders all conspire to increase the probability of developing pulmonary vascular disease at an early age in the absence of any other risk factor. And so I think we need to do a better job at screening our adult patients for perinatal events that could be informative for risk stratifying their probability of developing pulmonary arterial hypertension. And I think part and parcel with that is rethinking the spectrum of clinical risk associated with hemodynamic parameters. These are data from the national VA cohort that I have published on in the past, showing the association between mean pulmonary arterial pulmonary pressure and mortality hazard when pressure is modeled as a continuous variable. And although we know that original definition from the World Health Organization affirms the importance of elevated mean PA pressure at or above 25 millimeters of mercury on outcome, we also know that pressure levels below that are independently associated with differences in outcome, and also are quite common in referral populations and can account for almost a quarter of certain populations, depending on the study that you choose to look at. And so what we're seeing here is data that's consistent with a shift in our understanding on what hemodynamic parameters are clinically important. We can extend this information to include PVR, whereas the classical definition of a cutoff of 3.0 Wood units is often used to identify patients with hemodynamically significant pulmonary vascular disease. We also know that based on this data set, that PVR levels well below that are associated with differences in clinical outcome. And so I think the overall theme here that we're pointing to is a shift towards focusing on earlier detection through risk factor identification and earlier detection of disease onset by recalibrating the hemodynamic parameters that we use to define the disease. And I'll end just with a brief cautionary note that although I learned this disease as really exclusively a vasculopathy affecting distal pulmonary arterioles, we know that in the contemporary era, it's a much more complicated disorder. And it's one that is better characterized as a systemic disorder. We know that right ventricular dysfunction is independently associated or observed in these patients, particularly in connective tissue disease, irrespective of afterloading conditions. This is a disorder of dysregulated neurohumeral axis signaling, volitional muscle atrophy, and a number of other constellations that I think will give us insight into opportunities for diversifying our therapeutic strategies to improve functional capacity, organ system across all systems, and differences in opportunities to improve overall quality of life. Right heart failure itself, of course, sort of the end stage event associated with pulmonary arterial hypertension, is a widely heterogeneous and widely diverse phenomenon. And I think we're starting to appreciate a little bit better just how complex this disorder is. And hopefully this will inspire some to investigate novel opportunities for drug development and for improving outcome. So in conclusion, in clinical trials, PAH outcome is improved with single or dual medical therapy compared to the original experience. In real world practice, PAH outcome is also improved, although the extent of this effect is not as certain. We think that earlier diagnosis is likely to be an important opportunity for optimizing clinical benefit of medical therapies. And I think profiling developmental biology, perinatal events, and other disease drivers in the young is an exciting new frontier that's quite promising in the field of clinical PAH. I appreciate your attention, and I'm glad to answer any questions.